I didn't mean to do that yet. Good evening, my good people. Comment, let me know you're here. Welcome. We have a wonderful episode for you tonight. Come on in. Hey, Shirley. Happy birthday. Hey, Alana. Thank you. Try to get your husbands and the men in your life to watch as well. We're talking about the men's today, okay? Come on in. Come on in. Come on in. Shirley, you're welcome. I hope you enjoyed it. Come on in. Please share this on your pages and make sure that you subscribe on my website, tjnanceministries.com, or on Instagram, TJ Nance Ministries, on YouTube at hashtag Healing is the Only Agenda, so that you can stay with what Tisa's Benson Musings is doing and Tisa joining Nance Ministries. Yay, Shirley, thank you. All right, come on in. I'm going to give a few minutes for us to gather in because I think this is such a critical topic that I don't want anyone to miss it. We are going to be, again, talking about men's health and the men's health crisis that currently exists, that we didn't know existed until COVID came and wiped out so many. So I want us to have a good conversation about this tonight. Tag your friends, let them know they need to join in, especially if they have men in their lives whom they love. If they have spouses, if they have sons, if they have fathers that are still alive, they are going to want to hear this. We have a medical doctor who's going to be sharing with us. So please comment in the comment section and let me know you're here. I'm so excited. Come on in. Waiting for some of my tried and true faithful ones to come on in the room as well. This is a topic that you don't want to miss. Come on in. Come on in. All right, I got 9:03. People will come in as they come in. Luckily, this is one of those platforms that if you miss it, you can always go back. People can share it. It is a beautiful night. Maybe some people are out. Okay, hopefully with their mask on and our social distancing. But I want us to get started because I want to leave our guests as much time as possible to be able to, hi, Kristen Miller, thank you for coming on, to be able to talk to us about this topic. As I mentioned, June is Men's Health Month, Health Awareness Month, and so we need to have this discussion. So let's get started. All right. Good evening, everyone, and welcome to another episode of Tisa's Rants and Musings. This month, June, is Men's Health Awareness Month. And one of the reasons that I wanted to actually talk about this topic is because some of us was just catapulted into the revelation that we really do have a men's health crisis happening. COVID came, it hit the Black and Brown community really, really hard, but then it hit our men even harder. So so much or I should say, we lost so many men to COVID-19. And it just showed for us that we have to have a discussion about men's health and what's going on so that something like this doesn't happen again. How can we prevent this from happening on our watch? And so I wanted to have this discussion, and most of my audience is women. And sometimes as women, we don't know how to support the men in our lives with their health. We don't know what to tell them. We're afraid to sound like a nag, to keep telling them to do things. So I wanted to bring a professional on that can kind of help us have this conversation, help us understand what's been happening, what happened with COVID, and what can we do about it. The whole point of the month and having these discussions is to really raise awareness of preventable health issues and encourage early detection for our men, because some of this, as we probably will find out, it was preventable, right? If we knew certain things and if we knew how to support, knew how to help. If you have men in your lives, I am asking you to please share this or have them watch. Or if you have women, girlfriends in your lives, and they have men in their lives and they don't know what to do, this is an episode that they don't want to miss. We're going to be actually doing a series on this topic. So yeah, you want to keep coming back so that you can get all the information that you can, because again, healing is the only agenda. But we can't heal from what we won't acknowledge. We can't heal from what we won't deal with. So in order to help us, hey, Rebecca, hey, Pastor Eunice, hey, Lakeisha, in order to help us have this conversation, I have a special guest on. Her name is Dr. Kristina Johnson. She's a physician at Maplewood Family Medicine, and she's also on faculty at the Overlook Family Medicine Center. She specializes in preventive care, and she has a passion for teaching, for educating, and being community oriented and being out in the community, helping people understand health and wellness. She's been on the front lines of this COVID pandemic, and so she's taken some time out of her busy schedule to come on to talk with us, to just help us understand what was going on, what's been going on, and what do we do. Okay, so please help me welcome Dr. Kristina Johnson. Yay!
Hello. How's everybody doing? I hope everybody's well. That's how we start most of our conversations nowadays, just checking in with everyone and hope everyone is well. Hope your families are well. It's interesting. I haven't really spoken to very many families, particularly African American families, who have not had someone who was affected by COVID-19, if not someone in their own household, a family member, a friend, a neighbor, just someone in their immediate sphere of influence, or just their circle, who was affected by this. And I would definitely say it's highlighted a lot of things in our society that have to change. And hopefully anyone who's watching this, and this is the hope that we all have when we do these conversations, when I go out into the community, is that, whatever you're hearing, I hope that if any of it pertains to you, it's helpful for you, that you use it, and that you use it for to kind of achieve your best health. That's the goal.
Yes.
And that's
to get us started. Yes, yes. Tell us a little bit about who you are. Tell us a little bit about yourself, of course. But I think to just get us started, help us understand what happened. One minute we were fine as a community, the next minute we heard there was a virus, and the next minute we were dropping like flies. And our
Right.
men especially were
Right.
just dropping, leaving here.
Right.
And young, old, I've
Right.
younger friends, I've had older people I've known. It didn't seem to matter
Right.
between the age,
Mm-mm.
the impact. So kind of tell us.
So, from my vantage point, and also kind of giving you a little bit of my own background, I'm a family medicine doctor, and family medicine doctors differ from internists in that we treat the entire spectrum of life. We treat newborn infants, we treat people on their dying breath, with their last breath. We treat everyone, whole families. We love to treat whole families, and so as you can imagine. A normal day for me is going in the morning to do teaching with the residents at Overlook Family Medicine, and in the afternoon I see my own patients many afternoons, some Saturdays too. And I don't know that anything in my training necessarily prepared me for this, because I don't know how you felt, but I felt like this is something that just came and it took over my whole life. Everything that you do, everything that you think, how you get up and decide to go out of the house, go to the store, shop, hang out with your friends or family, make big decisions, small decisions, it all became sort of subsumed by this virus and seemingly out of nowhere. Now, I do train with one of the younger doctors in the practice, so I do train with people who've been through other outbreaks, Ebola, MERS, and importantly, HIV, in the late 70s and early 80s. And I have colleagues who've been through those pandemics as well. The dynamics of those pandemics differ. But my formative training was at Howard University. I was actually in college. I went to a sinus college. I was a French major. Interestingly enough, don't ask me anything in French. I will understand you, but I probably will not be able to speak. I'll get a little hemmed up. But back in the day, I was a French major, and then found my way to research, and got a master's in biomedical sciences at the College of Osteopathic Medicine in Philadelphia. Then did some research at the National Institutes of Health. So if you've seen Barney Graham and Kizzmekia Corbett on the news, that's the lab that I was in. And yes, I did work with Barney. And yes, I worked with Kizzmekia back when she was just in high school. And then right after college, I went into medical school. I got both my MD and PhD. So it was a very long program. But I completed both degrees and then started residency here at Overlook Hospital in Summit. And then I stayed on as faculty in the practice. And heading into this year, I had all kinds of plans for myself, as I'm sure all of you had. Some of you had travel plans and vacation plans and life plans. And then all of a sudden, your world changes all at once and you have to kind of adapt.
Yeah.
And the most significant thing about this particular pandemic is that it really has highlighted that our healthcare system has failed a number of people.
Yeah.
Intentionally, unintentionally. COVID-19 didn't necessarily, it did cause a lot of people to die, but the reason that it caused a lot of people to die is because a lot of people were already dying. They may have been dying more slowly. They may have been dying, without necessarily knowing it, or just living their lives and then all of a sudden dying before maybe they needed to or should have. So it really just pointed out the points in our healthcare system where gaps in quality, gaps in availability, gaps in knowledge, gaps in insurance, all of these gaps sort of combined into one. And then something like COVID-19 comes up and it just amplifies it. So all of these disparities that you're seeing in the numbers of cases, they're just amplifying what was already there. They didn't cause anything new. They just took everything that was already there in terms of our disparities and put a magnifying glass on them to really deadly effects. And just for background for most people, and most of you have been online a lot and you've seen, a lot of information, but COVID-19, it's actually SARS coronavirus 2. It's a virus. And it's not like bacteria that, if you leave some food out and it gets that funky smell and you're like, what's that?
Right.
That's bacteria. Usually that's bacteria. Or if you see something growing on top of it, that's usually fungus. But viruses, you can't really see them. They're microscopic and they spread in one form or fashion, either by touching, by sneezing, and it's in the droplets, by blood. So people who inject IV drugs or who are getting blood transfusions. So that's how viruses spread. And they need you and I to survive. They have to go inside of your cell and use your cell's machinery to actually make more of itself. Okay, and then they like certain tissues. So this particular coronavirus likes the respiratory tract. It likes the upper pharynx, and then it travels its way down into the lung, and it likes the lung. And then there's other kinds of coronaviruses, out there. But this particular version of coronavirus is just really, really deadly. It causes way more than just a lung disease, particularly in the people who wind up in the hospital setting. It can cause actual structural damage to the lung tissue. It causes what we call hypercoagulability. So that means that you have an increased risk of having clots and blood clots. We don't know why all of these things are happening, but those are some of the things that can happen. It's been associated with like altered mental status, kidney failure. We don't know if that's independent of the virus or because of what happens when someone's infected. They just stop eating and drinking, and then their kidneys are not getting enough fluid, so then the kidneys fail. Because the kidneys fail, you can't really regulate all of your electrolytes, the chemicals in your body that help things run, and so then your brain kind of gets wonky. We don't know if it's necessarily one-on-one or cause and effect, but this is what we see. And so this virus it is deadly. The warnings to stay home, the warnings to use masks, the warnings to wash your hands. There's reason for those warnings because they can help protect you from spreading infection. And it's going to be important moving forward, that you use those things that can protect you as much as you can, even as restrictions kind of, lighten up and we're out and about more often. You still have to use all of the appropriate preventive measures that you can to kind of prevent the spread of this virus. Now, in terms of the question that you asked about the numbers and what's going on, so
particularly with the men, what I said, particularly with the men, it just seemed it wiped out so many.
It did. So that's attributable to a couple of different things. And again, like I said, the virus did not start that process of a lot of men dying. It just amplified what already exists. And I say that for a number of different reasons. Number one is that Black men already have the sort of lowest life expectancy of all people groups or the current ethnic we identify in the United States. So longitudinally from 2006 to 2017, this is just a table I pulled, but non-Hispanic African-American men up until 2017, their average life expectancy was 71.5 years. That's non-Hispanic African-American men. White men, 76.1. Black female, 78.1. Hispanic male, 79.1. Non-Hispanic white females, 81. And Hispanic females, actually, they have longer life expectancies than other ethnic groups. It's up at 84. So already, non-Hispanic Black male already have a lower life expectancy than other ethnic groups. So then let's unpack that. What does that mean? What kills most people in the United States? It's cardiovascular disease. Okay, that's what kills most people in the United States, even up until COVID. That's going to skew the numbers, but cardiovascular disease kills most people in the United States every single year. And so, what are the risk factors for cardiovascular disease? High blood pressure, uncontrolled diabetes, obesity. Okay, So those are major risk factors for cardiovascular disease. So when I say cardiovascular disease, I mean blocking your arteries, clogging up your arteries with things like cholesterol, or in the case of people who have diabetes, clogging your arteries with sugar. And it's sugar. When you pour sugar in a cup, that Kool-Aid cup, you swirl it around and it gets thicker and thicker and thicker, and so it's viscous. And that's exactly what's happening in your blood. That slows down the traffic, so blood can't really flow where it needs to go. That turbulence can damage the blood vessels, and that leads to a process that eventually can block that vessel off. And that's what a heart attack is. It's one of the vessels around the heart. It gets blocked. That part of the heart stops beating. That is what a heart attack is. So all of the things that lead to cardiovascular disease are the things that are disproportionately represented in terms of prevalence in the African American population, including Black men. Okay, so high blood pressure, obesity, diabetes, all of those things. Top 10 are some cancers as well, in terms of the killers, the top 10 causes of mortality in the United States. And there's a caution to saying that Black men don't get certain kinds of cancer more often than Caucasian men. Numerically, it's a numbers issue, because African Americans total only make up 13% of the population or so, the United States. Right. So they're not going to make up most of the people who have cancer. What they do make up, they die more frequently from cancer. They are diagnosed later when it's already spread throughout the body. So it's more severe when they're diagnosed. And the same thing with cardiovascular disease. The studies show that African American men, compared to other ethnic groups, don't get appropriate screenings. They may not be treated with the appropriate medications. They may have longstanding untreated disease, and that contributes to it. And then suddenly there's an event. So those are some of the reasons why already African American men were already predisposed to getting some illness worse than some other ethnic groups. And that's just looking at the risk factors for cardiovascular disease. Okay, we're not even talking insurance status, also less in that population. Having a primary care doctor, somebody you can talk to, somebody you can trust, somebody who's looking out to make sure you're getting your screenings, also less in that population. So there are reasons that then you take all of that information about the health status of African American men, the preventive needs that African American men have that are not necessarily being met, and then you pile on top of that a deadly virus. Okay, I need to also mention the environmental issues. So history has cordoned off certain populations in certain places in America. So African American men may be more likely to live in places that have a lot of environmental issues and toxins that lead to respiratory illnesses like asthma.
Right.
If you have pre-existing lung disease, something like asthma, then you may not fare as well with a strong respiratory illness like COVID-19. So then, again, the environmental causes, and then there are the personal causes, the things that you can prevent that you already do yourself, these health habits that people have. So people who smoke, for example, that damages the lungs, it damages the blood vessels. And so you damage the lungs, then you're at risk for things like lung cancer, also in the top 10 in terms of mortality in the United States. And you're at risk for cardiovascular disease, also in the top 10. So if you add all of those things on, the modifiable factors where you can do some prevention, the non-modifiable factors like just your inheritance, so exactly, poor health habits contribute as well. So if you add all of those things together, then you have a population of people that often are undertreated. They're not seeing the doctor enough to prevent things from happening. And then when things do happen, when you do get diagnosed and you are diagnosed with high blood pressure, you are diagnosed with diabetes, you're not getting to the doctor enough to treat it and control it so that you prevent the progression of these diseases. Okay. And then that's how you wind up with a population that has worse outcomes. in those areas: diabetes, high blood pressure, coronary artery disease. So that's the blocking of the arteries that I mentioned. And just kind of focusing in on that particular health topic, because that one is one of the leading causes of people who die with COVID-19. So then let me switch gears to what you see. So when COVID-19 started, I told you about my normal routine, and that routine got changed overnight. So first, everyone stopped seeing patients in the office. We were doing telehealth, televisit encounters, getting screening for a lot of people for COVID-19, but no patients were really coming in the office. And in the hospital, the numbers of COVID-19 patients were just growing. I mean, they were changing units that were completely unrelated to intensive care, to COVID units. So every floor, just about almost every floor in the hospital was a COVID unit. It went from 1 to 2 to 5 to 7. Then they had to switch certain operating rooms, and had to switch ICUs and add ICUs. So there was an intense period, a peak, where there were just a lot of COVID patients, hundreds of COVID patients in the hospital, all being managed at the same time. Not everybody was on a ventilator, but the people who were in the hospital had really severe respiratory illness or coagulability, so there was clotting, or altered mental status, so they weren't eating, their kidneys were failing. So we were managing those things in the hospital. And the way that I was brought in, I initially volunteered, but then since I worked in the teaching practice over at Overlook, they had done some organization so that our practice just sort of managed a floor of patients, so a whole unit of patients, and then we just took turns. So we would go in once every 3 weeks or once every 4 weeks. We would take that whole week, and we'd be in the hospital managing the COVID-19 patients. And so it was pretty intense. And I was there. I was really called in during the peak. I was kind of the peak weeks where all the beds were pretty much full, and there weren't a lot of people dying, but when people died, it was very acute, or sometimes it was very slow, but always very painful. And you were limited in what you could really do. And we know now that we were hoping that some of the medications that looked to show some promise in smaller studies would be helpful in the broader population of people who were in the hospital with COVID-19. So that's the hydroxychloroquine that you've heard of on the news. That's the azithromycin, the Z-Pak that you've heard of on the news, and they were all standard of care. There are medications that modulate the immune system, something called Actemra. You may have heard that on the news. Remdesivir, may have heard that on the news. And unfortunately, because this is an ongoing pandemic and we're still finding out information as people are infected and survive or don't survive, at the end of the day, there's still not a cure for COVID-19, and we don't know what the best effective treatment is. It's not hydroxychloroquine and azithromycin. That causes a lot of cardiotoxicity. So it makes the heart beat too fast. It was causing people to have encephalopathy, where they kind of just go wonky. So that's not standard of care anymore. Actemra is not necessarily standard of care, that immune modulating medication. Remdesivir is only for people who are already in the ICU and kind of, they don't have a lot of chances.
That's the one the president was talking about.
So hydroxychloroquine is the one the president is currently taking for some reason. I don't know why, but I think that this particular period of time is sort of anti-fact. And so instead of kind of going with, what we know to be the case right now, I think he's kind of stuck in what he wants to be true, which tends to be characteristic of this particular political environment. And he's made it a political issue, like some kind of stand against, I don't know what, but the idea that hydroxychloroquine is really the treatment for COVID-19. And we now know that it's not. It may really not help very many people. It may cause more side effects than anything else. Wow. And resorting to those medications, it's because oxygen and supplementation with oxygen and just general treatment is not really working anymore. So we might try other things to kind of help a patient with COVID-19. So, but to be honest with you, the most difficult day in the hospital for me, it was a Wednesday. I won't say which day, but it was a Wednesday. And we were working with a family who were dealing with a family member who was dying. And part of our training as clinicians, it is our goal, is our objective to keep everyone alive and as well as if we can keep them. But this particular patient, no matter what we did, was still dying. And part of the difficulty with COVID-19 is that family members can't come into the hospital and hold hands and be by the bedside. We have iPads and stuff now, but I think that particular week we didn't have them in every room yet. So trying to explain to them what I'm seeing, and why
Wow.
I'm seeing that he's dying despite, everything that we're trying to do is difficult. And it's another family member who's just kind of making a decision that the patient wound up declaring themselves, and that means that they were dying and they died. But
Wow.
up to that point, there was this period where, and this is often the case, it's a period where people are just reaching and grasping for something to work. And we were doing the same thing. We really, really wanted people to survive this. And some people just came in they already had uncontrolled diabetes to the point where they were on dialysis, and this was just too much for their system. They already had long-standing asthma and maybe some sleep apnea that had gone untreated, which damages the lungs as well and the heart as well.
Wow.
And,
Wow. Okay, wait. Because this is the first time I've heard sleep apnea come into the conversation and COVID. Because I have so many family members that suffer with sleep apnea. And the thing about sleep apnea is you usually don't, people go so long having it. They don't do anything about it. They don't like wearing the mask at night. They don't like it. And, that I hadn't heard that. But we also have some questions coming in as well about the role of the prison population. Veronica's asking, I have some of the stats on Black men been skewed by the prison population. And she's saying her dad still can't get a test, which is just terrible. And somebody else is, Katina's asking, what can she do to make sure the Black men in her family live longer than 71? So, I mean, it breaks my heart, right? It's hard enough being Black in America. It's hard enough being a Black man in America. Not only do you have to contend with the regular disparities that you already spoke about in healthcare, in environments, in where we live, then we get something like this, and it's another form of suffocation, right? You got the police on people's necks, but here you have COVID in people's lungs and they still can't breathe. And it seems like as a community, we're just suffocating from so many different ailments, And so what do we do? Like, how do we start to help? How is me as a woman, and I shared about my dad and what he went through, and he had a massive tumor in his heart that stopped him from being able to breathe, but he died the same day that George Floyd did, right? And all of those COVID people who died that day all died from not being able to breathe, And so we just feel like as a community, we're suffocating out here. But I feel so helpless. I couldn't get him to talk about death. I couldn't get him to be truly honest about his health condition, right? He always wanted to make me feel like he was doing well. Even when he was dying, he would put on his best voice, and as a parent, right? They don't want their children to worry. So he would put on his best
voice. Be a burden, they don't want you to worry about them.
They didn't want you to be burdened. And the next day I get an emergency call, he's dying. And I'm like, wait. This is all too fast, right? So what can we do? I mean, I know I'm throwing a lot of questions at you, but yeah, help us wrap our heads around.
So let's go kind of like rapid fire. Okay, like I said, I'm a teacher, so let's start with the sleep apnea component, and then we're going to circle back to the what can we do. So sleep apnea is like if you were to dive into a pool and keep your head under the pool for a while, You can hold it for some time, and then even after your natural reflex to breathe kicks in, you may even be able to psych yourself out and just stop breathing for enough. But eventually you will burst out of that water to get air. That gasp, that I have to breathe. That's what's going to happen. It's one of the organic. It's one of your first reflexes when you started out as an infant, right? So what sleep apnea is there's something obstructing your airway when you're breathing. It's either the size of your tongue, the mass of your neck, or the weight of your body, and it's compression on the airway, particularly at night when you're laying back and you're just lying down to sleep. It could be you have like large polyps or something in your upper airway or in your nasal passages, but there's some blockage of some sort in your airway. And so what the body does is at some point that blockage gets to the point the body can't stop it. So it stops you from breathing. You stop breathing. And that's one of the things you notice with sleep apnea is we call it apnea or apneic episodes. You stop breathing. And so this is the person who you sleep next to who and you hear the snort and they start breathing. Okay, that's a witnessed apnea. That's a gap in their breathing. And what's happening is they're underwater. Whatever the obstruction is has blocked them from breathing. The air cannot get in. And that gasp is their body's way of saying, I have to breathe. Often it comes with them moving around because the body is trying to get air. Now, if you stop breathing, it stresses your heart because your heart needs oxygen. Your lungs need oxygen to function. Everything needs oxygen to function, and your brain needs oxygen to function. So you have all these sort of micro instances during these apneic episodes where your heart, your lungs, your brain are starved of oxygen, and that is additive. So over time, you put so much stress on your heart and on your lungs. You put so much stress on your heart that if you do everything else and you don't have any other medical issue, if you have sleep apnea, you can still have a heart attack. You can still suddenly die, just not wake up one day with untreated sleep apnea. This is not hyperbole. This is real.
Wow.
If you have untreated sleep apnea, you can have regular hypertension, like with your heart. You can also have pulmonary hypertension, where the blood vessels in your lung, the pressure in your lung goes high, which backs up and causes heart issues. And those are two of the most serious things that can happen besides just dying in the middle of the night because you have not been breathing, or going into heart failure. All of a sudden, heart failure, where you're on medications in the hospital, getting cathed, all this stuff immediately. So sleep apnea is a silent killer. And it's often something that's untreated, and we laugh. Oh, she snores, or she just snores so loud.
Right.
You find out from the doctor whether or not you have sleep apnea. And there are certain signs. So if you're snoring, and certainly if there's witness apnea, if you have daytime sleepiness, so you go to sleep at night, no matter what you still feel tired. Even if you got a good night of sleep, you're still kind of groggy, especially like later on in the afternoon. It's a silent killer. And as you can imagine, if it puts all that strain and stress on your heart and on your lungs, right now, before COVID-19, we actually added that on to screening criteria for people who were undergoing surgery, because people who were undergoing surgery where they were being put out for their surgeries and intubated for their surgeries, if they have untreated sleep apnea, it makes it harder for them to get that tube out. They have worse outcomes post-surgery. Wow. So untreated sleep apnea, that's, like I said, it just amplified what was already, COVID just amplified what was already there. So they had pre-existing heart issues, pre-existing pulmonary hypertension from sleep apnea, and then they get COVID. And now they really can't breathe, right? So then what can we do? Like I said, this disease just amplified all of the problems that we knew existed that are already there.
Right.
And now, just as people are out in the streets and they're marching because of injustice, we have a role in helping to facilitate our own health, our own bodies, the health in our own bodies, it's almost as a form of radicalism. It's like saying, I refuse to be unhealthy. I refuse to go without my screenings. And it's hard because women usually go to the doctor. One of the reasons why is because women seek primary care is with pregnancy in particular. So once women become pregnant, they will go see the obstetrician.
Right.
they will go and make sure that they are having a healthy pregnancy and that they deliver. And obstetricians are primary care providers as well as they are surgeons. So they're making sure you get your vaccines. They're making sure that you're eating well. They're making sure that you're participating in some kind of physical behavior that's healthy, sexual behavior that's healthy. You're getting your STI or sexually transmitted infection screens. You're treating the gonorrhea. You're treating the chlamydia. You're treating the HIV. So they're doing all of those things too. And so a lot of women, if they don't see a primary care doctor, they will see an obstetrician, and then that kind of gets them plugged in their middle adulthood. Whereas men, there is no comparable physician during that period. So when they're younger, mom has to take them to the pediatrician because they have to get their school forms filled out. They have to play sports. If they're playing sports, they have to get the sports physical done. So that's another point of preventive care in their youth and often in their adolescence. But by the time they go to college, once they're young and they've kind of been healthy, they go to college, you may not see them again after that pre-college physical. You may not really see them again for several years, if you really see them at all, until maybe they're early adults. And there's this gap where men don't come in. And maybe when they're 30 and they're thinking of starting a family, so they're like, oh, well, my wife, my partner, my spouse, my baby's mother, whoever, that person is now having a baby and she has to do all her stuff to be healthy. What am I doing? And I get a lot of men who come in for that reason. Like, well, she's going to be healthy, so I got to do what I have to do. The other reason that men come in is when they have family members who are ill. So dad died of a heart attack. Uncle so-and-so had cancer. My brother had something, it just came up and now he's in the hospital. And I haven't been to the doctor in a long time, so it's time for me to go. I just got married.
Right.
And so a lot of times men will go with transitional periods, to the hospital, especially if everything has been okay. And so that's another sort of, I'm kind of listing here some barriers. The other thing is family dynamics, and it's something like what you were alluding to with your dad, and a lot of people experience, which is, they're playing a role in the household. I'm the strong one. I'm the annual checkups are important. So the men are playing a role. I'm the strong one. I am the one who takes care of things. I'm the one who does not complain. I am the one who gets things fixed. I am the one who will go get 10 jobs if I need to keep track of things. Even if it means that I'm eating unhealthy foods while I'm on that job, I'm going to get it done so I can get the money in the house or whatever. So they're not playing a role. They are being a particular role in their household. And often that role takes precedence over pursuing what they need to do for their own health. So if it's a truck driver and you say to him, you can't eat those salty foods, and he says, well, that's what I have when I'm out on the road. I'm not going to stop going on the road to eat the healthy food. So, it's a negotiation on how you can fit healthier things into your lifestyle, but that lifestyle comes first. So often the roles that you play, your dynamics in your family, and then also, men are not as verbal often. So they may not actually talk about what they think or feel. They may just feel it. We as women, we have women groups, we have best friends. We just share our hearts. We cry, we laugh. A lot of men, they don't do that. They kind of hang out. They may say, oh, my woman, she tripping. My man, he tripping. They may say, they may not delve into deep. They may not treat depression. They may not, access resources to treat depression, even though that's what they have. They might tell a friend, I don't know, but they still go and watch the game and maybe just focus on the game, but they don't actually get into what the issues are. And untreated depression worsens cardiovascular disease. You know what I mean?
So it's sort of like I feel like it's a domino effect, right? It's
a domino effect. There's a lot of value. Culture built into being a male, built into their culture to say, don't communicate, don't talk about how you feel. When something hurts, you just shake it off. You strong,
right.
You got it. You don't complain. Don't waste money. Stuff like that. So there are a lot of factors that kind of prevent men from themselves stepping forward and saying, okay, I need to be a priority in taking care of myself. There's a lot of different reasons for that. And then we're going to go over what we can do about it.
I was going to ask. I was going to say, what do we do? Like we can't keep this and people been hearing me do this rant about this is the great reset, right? We have to reset our thinking. We have to reset our ways of being. Some of the ways that we've been before was okay. We could survive with it. Now we just can't. Just like we can't survive being complacent about white supremacy, racism, police brutality. This is just as critical, right? Mm-hmm. We can't be complacent about our health as people, but also with the people in our lives whom we love, especially our Black men. So what do we do? How do we approach the conversation? How do we get a man, especially a Black man, who comes from all of those things you talked about, that machismo kind of, I'm the man, I'm good, I don't fix it till it's broken kind of mentality, and that fear, maybe they will tell me something's wrong, so I'm not going to go. All those barriers that you listed, how do we somehow connect with them to raise the red flag, or to even have the conversation that we can't keep going forward like that? We can't just keep being complacent or waiting till you break down, because now break down don't mean you're out for a little bit, a couple of weeks. Break down could be dead.
Yes, very, very much so.
Dead, and I can't even go into the hospital where there could be so much implicit bias and advocate for you.
That's right.
There's so much that can happen that if we start with some prevention could have helped along the way. But how do we even start having that conversation?
So then, the first part of the conversation is that, I found, especially with my patients, I don't tell my patients what to do. It doesn't work. And relationships are different. So if you're in a romantic relationship with someone, a partnership, if you are a parent and it's a child, if there's that dynamic, then your ability to influence the decision making of that particular male in your household or in your family, that's how it's going to differ. It really just depends on what that relationship is and how it is. But for spouses, what I have found is that often, in terms of, so one of the steps is identifying really a trusted provider, a trusted person to really talk to about their medical issues. Now, your needs as a woman for who you want to be your primary care doctor may differ from their needs. They may want somebody who's just going to get in there and tell them what they need to do and get on with it, or get on them about their stuff. Or they may want somebody who may be just a little bit more conciliatory and just kind of maybe will bargain with them on things that they can do and not do, and talk with them and kind of work with them, so to speak. But the point is that, finding a trusted provider is one of the things that you can do. Now, let's say you don't have anybody. They don't want to see your doctor. You've mentioned it to them.
Right.
Talk to a friend or a family member. Talk to their homeboy. Who does their homeboy see? Who does their homeboy's homeboy see? Who is his circle seeing? If one of them has a doctor that they've been seeing for years, and if they're friends, they may want to see that person. They may agree to see that person. Men will go in for things that bother them, that are core to them. So, for example, a lot of men will come in because they're having sexual issues. So if they're having difficulty,
come in for that.
If they're having difficulty with erections, if they can't come, they will come in, and then that's when you go, well, you have diabetes, that's why you can't. You have high cholesterol, that's why you can't. Or they used to play basketball and they can't play basketball anymore because, they just get so out of breath and they're tired, and they'll come in because of that. I just kind of want to be able to go and do this, so they will come in for those issues. So then encouraging them for the issues that bother them, say, listen, have you talked to a doctor about that? And now there's a lot of fear right now, but there's also a lot of opportunity. So let's say your partner, your spouse, your friend, your brother, your whoever, he doesn't want to go to the doctor. He doesn't have to. He doesn't have to go into anywhere to go see a provider. He can look online. If there's a provider that's of interest to him and he just wants to have a conversation, he can do a telehealth encounter in his bedroom, in the bathroom, in the shed, just kind of a one-on-one conversation with a provider, just to introduce and talk and say what's on his mind. If something's bothering him, by phone, if he's too embarrassed or he just doesn't want to make anyone afraid. Leverage, as you say, leverage that service. It's available to you, and they're all over the place now. I don't want to be an advertisement necessarily for Atlantic Health, but everyone is doing telehealth now. It's going to be an ongoing part of medical practice for the foreseeable future. So leverage that, take advantage of that. Some people will schedule their partners, schedule their husbands, schedule their whoever. And sometimes that helps. If you have a provider who can talk and kind of draw things out, it helps. Sometimes it doesn't help because they just resent it, or they feel like they don't need to be there, or they, don't want to be there. But what you can do is encourage it. So if there's something going on, people go to Dr. Google and they say, well, try this and try this herb and this cream and this whatever. And you could also say, why don't you talk to a doctor about that? And then if they say, oh, well, I don't know, you say, well, here's one. Have a conversation with him or her. Set it up. You need help with the appointment, or just call the appointment, or have them ask a friend who they see for their particular issue. And the other thing is to familiarize yourself with the screening guidelines. The screening guidelines are not a secret. And it gives you an opportunity to know, what is it that I need to be doing for myself? But what does he need to be doing for himself as preventive care? And what may be missing? This can also empower you, because if you're seeing a provider and they're not talking about these screening guidelines, and you have your checklist, of screening guidelines, what you do is you Google USPSTF.
Wait,
screening.
Hold on. Get that down.
US
or US?
All capital. U is an umbrella, S is in Sam, P is in Paul, S is in Sam, T is in Tammy, F is in Frank. USPSTF screening guidelines, A and B. And on that list are all of the screening guidelines that are recommended across all ages. Okay, so long, A and B. And it's a very, 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 very long list. But some of them are specific to men, right? Some of them are talking about prostate cancer. Some of them are talking about colon cancer. That's men and women, right? Some of them are talking about if a person has a smoking history and they're smoking cigarettes. There's a lung cancer screening. Has your spouse had that? Some of you are talking to your doctor about these things for yourselves, but do you have a sense of some of the things that might need to be done for the men that are in your family?
Let me get some clarity before you move on, because I think I'm writing this wrong. This is USPSTF. Is this a .com? Is this a...
No, it's not a .com. You can just Google. Just
Google that. Okay. I think I started thinking it was a .com.
So do it this way. USPSTF A and B recommendations. Put it in that way.
And B. So you Google that.
And the link that's named that will tell you all of the recommendations that are recommended across the population for all manner of diseases. And these are things from vaccines to cancer screenings to screenings for people as they get older. There's certain things that you need to evaluate as you get older, particularly vaccines and some cardiovascular testing and screening. Those are the things that you can check out and see, okay, is that what I need to do? The other thing is you can familiarize yourself with what kinds of screenings are available. So for example, I always have patients who are very afraid of colonoscopies. And colonoscopies are procedures to check for colon cancer. And how you check for colon cancer is you evacuate your bowels. So that diet you went on to cleanse and all this stuff, that's what it does. They just give you some solution or tell you how to take a certain, like Malox and a combination of things to really flush out your bowel. And this is not a fake flush. This is a real clinical flush. You're going to get rid of all that poop that's aligning the walls of your large colon. And then they use a small fiber optic camera, and they look inside your large bowel. And your large bowel it goes down from your rectum, it goes across your abdomen and out on the other side. They cover that whole thing. And the reason that they do that is because if they see something that looks like colon cancer, or it could be colon cancer, they take it right then and there in the colonoscopy. They snatch it right off of the wall. And colon cancer is actually a slower growing cancer. That's why if you've had normal screening, you can wait 10 years before you get another screening, because it tends to grow more slowly, except in certain ethnic populations. So if you are ethnically an African American, you should be talking about colon cancer screening with your doctor starting at the age of 45, 45,
Wow.
50, like the general population. Not because we
Wow.
get colon cancer more often, because when we find colon cancer, it's often more advanced in African Americans. So 45 is when you start having that conversation with your doctor about colon cancer screening. And then if you have a family history, you should be screened 10 years earlier than the earliest case that was in your family. So if your family member had colon cancer at 42, you need to get a colonoscopy at 32, depending on the family member. So the
Okay,
screening
wait. You gotta slow down for me, girl. You got to slow down. So you're saying that if you have a family member who had colon cancer at a particular age, around that age that they got it, or earlier, you should be getting your own screening.
So you're talking about a primary family member. So you're
So that's
talking
like
about
a mother or father,
siblings, your
sibling.
mother, your father, or if there's a bunch of people in your family with all kinds of cancers, including colon cancer. So the cousin, the first cousin, the aunt, the uncle, the sister, the brother, your great aunt, the this, to that, your brother. So if you have that kind of family history, or you have a direct family history, so your mother, your father, one of your siblings, both of your siblings, if they have that particular kind of cancer, you find out when they were diagnosed with that particular cancer. And you may need to go 10 years earlier than they do, than they went, or when they were diagnosed, in order to catch the cancer. Because if you have cancer in your family, depending on the kind you have, it may be heritable. You may have a predisposition to develop this kind of cancer.
Wait, doctor. Because my father had colon cancer before he had this cancer. So he had colon cancer. He did the chemo thing, and he was okay. I mean, it took a lot out of him. He wasn't obviously the same, but he was older already. He was in his 60s before he. But I'm pushing on the door of 50. I got a couple more years.
You should. So then, if you have that family history, even though he was in his 60s, you should have been starting your conversation about colon cancer screening at 45. You would be a person to get it at 45 before 50. Yeah, that's what I would that's what I would have recommended for you.
Who knew?
And so, but you notice what's happening is, what you do is, when you hear that, you hear the general guideline, and when you're in the office, okay, this is a general guideline, and then you go, how does this apply to you in your story, in your family history, in your personal history? Because there's some people have personal histories. If you have Crohn's disease, if you have ulcerative colitis, if you have a history of chronic constipation, this just has no etiology. You can't figure out where it's coming from. You've tried fiber, you've tried water, you've tried all these different things, and you are still chronically constipated. There are other reasons to have colon cancer screenings, so again, going back to the conversation you're having with a provider about the screening, and that's just colon cancer.
That's what I was getting. And so that's what I was going to ask you, because we have a little bit of time, just a little bit of time left. So it sounds like one of the biggest recommendations, though, is to go see what these screening guidelines are. Look at them in juxtaposition to our family history, and start having conversations with each other. The men in our lives, our sons, uncles, whomever, as long as also ourselves, because there's so much I'm learning that I needed to do. And then having that conversation with our healthcare provider, our doctors. And it sounds like what you're saying to me, and I think this is one of the things I want us to maybe end on, is that the day and age of waiting for our doctors to tell us what we need to do for our health is over. The wide range of disparity shows us that we just don't get the health care that we need to have as a community. We're not saying people are doing it on purpose, but for some reason, I'm 47, right? I'll be 48 this year, I think. So, but I haven't heard that. I haven't heard that I needed to start getting colon cancer screening, right? There's so many things I may not know that I need to know. And
the reason is because you have to go every year. The guidelines change based on population studies. So 10, 15, 20 years ago, that wasn't in the guideline. And we were focusing on colon cancer, but that's a general principle. The guidelines change. Your family history changes. Your personal history changes. Your medical goals change. Your what bothers you will change as you get older. So then you need to know, if this thing is bothering me, is this a thing that is more than just what I'm feeling, or is it something that really needs to kind of be addressed? And I know we only have a couple. You said a couple, and we're wrapping up, and I know it's 1 hour, right? So I'll say this in terms of tips. I'll say this in terms of tips. So when children are young, get them used to going to the doctor. It's a normal part of life. Yay, it's time to go to the doctor this year. Let's get excited about it. In adolescence and when they're teenagers, you let them go to the doctor, but you also give them their independence. Let them speak to the doctor on their own. Let them ask questions to the doctor that they may have, because the doctor's asking them about their lives too, and they need to get comfortable having their own conversations about their health. As people are young adults, if you're partnered with somebody who's a young adult, if you're going into the doctor and you're looking to have kids, or you're looking to move, or you're looking to make big changes in life, say, listen, are you even healthy? Like, what's going on with your cholesterol? Like, what's when's the last time you saw a doctor? Just a reminder sometimes is all that they need. And in middle age, you're checking about, you're going to your visits, you're encouraging open dialogue. You don't have to tell anyone what to do, but you can positively influence them. Try to identify a healthcare provider, and certainly in the elderly, those same principles still hold charge. But that middle age, those younger adults, really encourage them to really engage in independent dialogue with their providers, so that they're not always just going when you tell them to go and they just sit there and get their shots and leave. That you say, okay, I'm going to step out, and this is his time with you. And he can ask what he wants, and he has questions, and he has worries or concerns. So that he can open up and know, like, now is I did have a worry about this, or I was thinking about becoming sexually active, or I'm concerned about this, or, and so they can have their own conversation with the doctor. And often that will help facilitate the normalization of going to the doctor as a routine part of your life. You go every year. The guidelines change every year. So go every year. When you see your providers, and encourage your partners, your spouses, the men in your lives to do the same.
Dr. Johnson, thank you so much. Dawn is asking, will there be a part 2 to this conversation? And yes, because there's still so much that we haven't even talked about, so much that we can continue to explore. So we appreciate you for coming on the show. You guys join in next week. We're going to talk even more about those health disparities, talk even more just about what we can do to make sure that what we've been seeing, we turn it around and not be complacent like we may have been in the past. Dr. Kristina, we know you're busy. We know you got so much on your plate. So please know that.
I love it. I love it.
Thank you. Thank you so much. I'm going to ask you guys
questions. We'll answer your questions. I'd be happy to answer them.
We have one last question. Is it safe now to still go get our annuals with this pandemic? Yes. Okay, bottom line, yes.
Opening, they have appropriate precautions in place. Some of them offer telehealth physical exams, so you can still get your screenings and stuff that you need. So you can still get your mammogram. Your husband can still get his prostate cancer testing. He can still get his colon cancer screening. And if he's too afraid, he doesn't want to leave the house, he's too afraid to go out there, do it by the video. And they can take care of the preventive health needs as well.
Thank you so much. Again, thank you guys for joining Tissa's Rants and Musings. Again, this is just all about us on a journey for healing, because #healing is the only agenda. And when we see what's going on in the world, we got to do it different. We got to be different. And then your information will help us do just that. I'm going to ask you guys, please share this, especially with the men. Share it on the pages of the men won't go to the doctor. Okay. Maybe that's another way. And I also read something. Don't be afraid to nag them too, right? Like, don't be afraid to be a nag. Some things are worth it. So definitely share this, please. And like I said, connect with me or have your friends connect with me on Facebook.com, TJ Nance Ministries. You can see the videos also on YouTube, my YouTube channel, Healing is the Only Agenda, and as well as Instagram, TJ Nance Ministries. Thank you. We will see you next week again, same time, same bat channel. Same guest speaker, Dr. Kristina Johnson. Thank you.
Have a good night. You still there?
I'm ending now.
Okay.